and thiazolidine-diones are relatively cheap. Lastly, a few words about the new drugs on the block, the SGLT2 inhibitors. We have DAPA, CANA, EMPA, and others. And of course, we know from our biochemistry and physiology in medical school that GFR, this is the problem with this mouse, of course, we excrete here filter out a lot of glucose, but it's all reabsorbed in physiology. And this is because of SGLT2, which mediates glucose reabsorption in the kidney. So, the renal handling of glucose in a non-diabetic individual, you end up with no glycosuria because of this enzyme activity. And yet, if you have somebody here, normoglycemia, this is the patient, it's all reabsorbed. But if you block that enzyme, then you increase glycosuria, and that's how these drugs work. And we know from early studies of the first one, DAPA, presented here at the ASD back in 2007, 8 years ago. And this was the first study of 47 patients. And we saw with DAPA at varying doses, this was in the early days, a change in fasting serum glucose there, quite significant compared with placebo as an add-on. And here you have the A1C changes from baseline, again impressive, but most impressive perhaps the weight loss. Now, there's been a lot of problems in recent years about scaremongering. The press loves stories. Diabetes drugs kill patients. Here we have the Indian Express in 2013 or thereabouts. Diabetes drugs may be linked to pancreas cancer. Bad news makes good press. We've had this with diabetes drugs cause bladder cancer. Bladder cancer, of course there hasn't. But the Kaiser Permanente study just published with 10,000 patients followed for 10 years shows no increase whatsoever in the risk of bladder cancer on pioglitazone. Now, this business about the GLP-1 agonists and the DPP-4 inhibitors came out during the ADA in Chicago in 2013. And I, together with my very good friend Bob Ratner of the ADA and friends from the IDF, sat down and said, there's only one paper which is flawed in many ways. We need to put out a statement. We put out a statement immediately, the same week that was released, that these drugs shouldn't be stopped without careful thought about it and consulting with your doctor. Now, Gandhi, who comes from Gujarat as your current Prime Minister, he loved this phrase, he who strives never perishes. Strive for the truth. And that's what, for the first time ever, the EMA working with the FDA did. And there was a joint publication in the New England Journal of Medicine last September, if I remember, or August, a joint paper showing they considered these, they thought there was no evidence from this one. So we were vindicated. Our position was correct. And we said then the long-term cardiovascular outcome studies will soon provide important new examine the one that's just been, I can't remember all their names now, but you know, they're all out there. There's no increased risk in any of these large long-term cardiovascular safety follow-up, not only of heart disease, but also there's no increased risk of pancreas cancer. So we've been vindicated. And yet again, we've had this. Headlines again. Diabetes drugs may cause fatal ketoacidosis. This is the SGLT2 inhibitors. And this, I found this study from Bruce Perkins, a friend of mine in Toronto. It was published about a year ago. And this was in type 1 diabetes, an open-label drug of EMPA in type 1 diabetes in Canada, 40 patients. They had 2 cases of TKA with relatively low blood sugars. And they felt that there might be a slightly increased risk of this in type 1 diabetic patients with off-label use of the SGLT2 inhibitors. And just published last week online with Diabetes Care was this paper from Ann Peters and John Buse and Earl Hirsch, very senior diabetologists in the United States. Case reports of 9 patients with euglycemic DKA. 7 had type 1 diabetes. The 2 type 2 diabetic patients was perioperative period that this developed. They all survived. Both cases, as I said, occurred post-operatively. They all recovered. And they conclude that SGLT2 should be used perhaps with some caution if you're using them off-label in type 1 diabetes. Generally, I think, of course, in type 2 diabetes, these are excellent new drugs on the block. They're safe. Perhaps in Muslims during Ramadan, when there's fasting in this climate, you need to be careful. And it's probably dehydration when you've got very low insulin glucose reserves and so on that leads to this condition. So as in all drugs, If the patient's ill, be cautious about using these drugs, especially if there's vomiting, you should stop them. There are other drugs that can be safely used, or insulin. So I think that's the summary there. Lastly, we discuss anti-hyperglycemic treatments, human insulins, and analogs. And of course, most patients with type 2 diabetes will eventually require insulin. The natural history, which we showed clearly in the UK PDS, is gradual loss of insulin secretion, beta cell function, and increasing need for other drugs. Most patients, as Rory Holman and Robert Turner wrote in a paper in The Lancet years ago, in the 80s or 70s, the quest for basal normoglycemia. And our policy in type 2 diabetes is usually to start with a long-acting insulin. We often use a long-acting an analog, such as Levemir, for example, which is a useful drug. And this is a useful drug in the type 2 patient going on to insulin, who may remain on other oral hypoglycemics as well. And of course, we have lots of options, as we show here. And finally, other considerations I've touched on. So knowing that time is moving on and it is late, I shall summarize. Glycemic targets and blood glucose lowering properties must be individualized. The cornerstone remains lifestyle management. Unless contraindicated, metformin remains the first optimal drug to be used. Combination therapy can be used with any of the others on the list and should be brought in earlier rather than later. And remember that most patients will ultimately require insulin. And we mustn't forget type 2 diabetes is not only a disease of hyperglycemia, but also of cardiovascular risk. Most patients will require a statin, and watch all this as well. Lastly, you'll be pleased to know that India was one of the best represented countries outside of Europe at the European Diabetes meeting last year. The USA was number 1, I think, and India was number 2 or 3 after the United States for number of delegates attending our annual meeting. We are delighted to have Indian friends and colleagues attend because we know there's always great discussion, and I've lectured all over your country, and there's never a quiet moment. We love good discussion, and that's why we love to have our Indian colleagues with us. Stockholm this year is a beautiful city. If you've not visited it, it's very pleasant, a number of islands. The climate, I can't guarantee will be as warm as here, but it could be as wet. But it's not a bad place. And we have our virtual meeting as well, and we look forward to welcoming you, many of you, to our annual meeting in Stockholm this autumn. Thank you very much.
Please. Yeah. Professor, thank you, Professor Andrew Bolton. Professor Bolton would be here, so we'll take up questions in the panel discussion. But I now hand over the mic to my co-chairperson, Dr. Nilivini.
Thank you, sir. Thank you for the excellent presentation, and I feel honored to be a part of this program. And for that, I would like to thank Dr. Sham and his team from Idea Centers for inviting me to be a part of this program and giving an overall view on the epidemic of diabetes across the globe and the causes for the epidemicity and like sedentary lifestyle. And I thoroughly enjoyed your presentation, especially some of the pictures showing the dog on the treadmill and the person who is supposed to do exercise sitting on the chair, and some of the slides like mentioning never try to live forever, you may not succeed, and human life is a sexually transmitted disease with 100% mortality. Thank you, sir. Thank you very much.
Having said that human life is a sexually transmitted disease, wonder thing is that we are now going to discuss about sexual health next this one. Let us discuss more about it. Thank you very much.
Ready to give a memento to our speaker, Professor Bolton. I would like to take this opportunity to just mention that we have amidst us another distinguished guest, Professor V. Shantaram. Professor V. Shantaram is a retired professor and head of Department of Medicine, NIMS, and I would humbly request you to please give the mementos to the chairperson, sir. moving on to the next topic, neglected area of diabetes management. I would like to invite on stage the chairpersons, Dr. Chanukya, Consultant Endocrinologist, KIMS Hospitals and Idea Centers. Dr. Babul Reddy, Consultant Endocrinologist, KIMS Hospital. Assistant Professor of Medicine, Gandhi Hospital.
Yeah, good evening to all. Now I brief Dr. Dikshit. So Dr. Dikshit has completed and also in andrology from UK, and he's awardee of Max Perry Conic Prize for his research work on recombinant TSH. Now he is working at the Central Manchester University Hospitals, Manchester, UK, and he has multiple publications in his credit. Now over to Dr. Dikshit.
Thank you. I'll just get by. Oh, there's a security alert.
Good evening, friends. Thank you very much for your very kind introduction, and thank you, Shyam, for providing me with this opportunity. My talk was planned as the last talk, and I was planning to tell you a bedtime story. That's what I told Professor Bolton yesterday. He has just changed it, and there's a little bit of entertainment for you while he rests. Sexual health is definitely a grossly neglected area. Lots of reasons for that. No time in our general diabetes clinic, cultural issues, social issues, patients may not be happy, doctors may not be comfortable to discuss that issue. So it is a problem which is not getting a lot of attention at all. Now, again, when we talk about sexual dysfunction, it is synonymous of erectile dysfunction. I hope by the end of this talk, I'd be able to convince you that there are much, much more to it. For the minority in this audience, as usual, ladies first, let's talk about some of the issues in women. I'm sure you know about this DCCT and the follow-up study, the EDIC study, the 10-year follow-up study. This is type 1 diabetics, about 424 patients. As you can see, diabetes affects almost all the aspects of sexual function in women with type 1 diabetes. What about type 2? It's the same problem here, but it affects postmenopausal women much more. The prevalence is about 60%, more than 60%. And even in the younger population, it's about 40%. Again, as you can see, all the aspects of sexual function affected. In both these studies, they said the strongest correlation was with depression. We got a recent meta-analysis, 26 studies, over 3,000 patients, nearly 3,000 controls. To summarize that, the prevalence of sexual dysfunction in women is higher in type 1 and also severe in type 1 diabetes. It is significantly associated with age in general, and it again confirms depression is a major aspect here. So, is it only psychological in women? This is hot off the press. These researchers did vaginal biopsy and used sophisticated tests to look at various aspects. And as you can see, there is something like microangiopathy going on here. Increased density of microvasculature. Difference in estrogen receptors, but androgen receptors are significantly low. It is also affecting nitrinergic system and aquaporins as well. I'm sure many of you will be familiar with aquaporins. These are water channel proteins, which are important for lubrication. How do we manage this? First of all, if we are uncomfortable talking about it for any reason, if the patient, nowadays younger women are having polycystic ovary syndromes, they are being diagnosed as having diabetes at a very young age in 20s, if they start complaining, I think we should at least be comfortable to listen to them. So strategies, of course, as we know, the strongest predicting factor is depression. We need to address that adequately. I mean, that is the major recommendation from Princeton 3 summary for female sexual dysfunction. There is some evidence about diet. Mediterranean diet has been shown to improve, and also physical activity. So 12 months of intense physical activity has been shown to improve the FSFI, the female sexual function index score, in almost all the parameters. So, anything specific? Yes, lubricants, local estrogen cream we can use. HRT hasn't got that great evidence. PD5 theoretically very attractive, but in the clinical trials not much of response. Testosterone, there's been recent practice guidelines from Endocrine Society in 2014, and they strongly discourage testosterone therapy for women. The only place where they suggest that we should give testosterone is when they have got hypoactive arousal disorder. So the bottom line here is aggressive control of risk factors and lifestyle measures. So we come to the major problem, which most of our patients, they are becoming more and more comfortable to discuss with doctors in the recent past. And this is from Tragedy of Bedroom, Leo Tolstoy's famous statement. If you look at male anatomy, just to recap, just to show you the relationship of prostate, testicles, seminal